Hello, my name is Carole Lunny and I'm with St. Michael's Hospital in Toronto. I'll be talking today about our work to advance the methods for overviews of systematic reviews by our team. Please tweet me at Carole_Lunny. So I wish to acknowledge the traditional ancestral and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations on which I operate in British Columbia. We have no funding and no conflicts of interest to declare. So since 2018, significant methodological advances in how to conduct overviews of reviews have been published. This presentation briefly orients participants to some of the methods recently developed by our team about overviews. At the end of the presentation, participants will know how to cite the prevalence of overviews, how to categorize overviews with taxonomy of PICO eligibility criteria, manage overlap in primary study data across systematic reviews on the same topic, henceforth denoted as SRs, assess discordance using the Haddad algorithm and know whether that algorithm is replicable, report on opinions of decision makers from a survey to determine how they compare and choose amongst competing systematic reviews on the same topic, and be aware of the development of the wisest AI tool to automatically quality assess and compare the PICO methods and results across systematic reviews on the same topic. So overviews synthesize the results of multiple systematic reviews and help to inform evidence-based practice. Methods guidance for overviews include the 2020 Cochrane Handbook chapter on overviews of reviews and the Joanna Briggs or JBI manual chapter as well on umbrella reviews. However, these guidance documents have certain limitations. For example, the Cochrane Handbook is only for overviews that synthesize the results of Cochrane reviews, not both Cochrane and non-Cochrane reviews. And the JBI manual is from 2014, and methods for overviews have advanced considerably since then. In 2017 and 2018, we published a comprehensive evidence map of methods for overviews to catalog all possible methods available to authors. These two papers can be used by authors to decide which methods might be best for their context. The evidence map also identified gaps in methods research for overviews, including grade for overviews, overlap in primary study across systematic reviews, and assessing discordance across reviews. I was also recently part of a team led by Lisa Hartling to develop a reporting checklist called Prior, seen here. Authors can use this checklist or standard to comprehensively report the findings of their overviews. In this presentation, we'll focus on our research over the past 3 years, which aim to fill some of these gaps. So first, what's the prevalence of overviews and are they growing in number? So a bibliometric analysis measures the impact of articles using metrics such as the journal impact factor and number of citations. Overviews have been growing in number, but it's unknown to what extent. Several investigations have found that evidence syntheses such as systematic reviews with meta-analysis received higher citation rates compared to other study designs, but typically represented only 4 to 6% of research output. So it's unclear whether overviews are cited equally as highly as systematic reviews, but it stands to reason that they might be, considering that they are a type of evidence synthesis. So our objectives for this study then were to assess the prevalence of overviews published between 2000 and 2020 and evaluate their citation rates and journal impact factors. So what did we find? Overviews, not so surprisingly, are growing in number, as is all evidence, as seen here in the figure on the right. A search for overviews and their synonyms was done in Medline, the Cochrane database of systematic reviews, and Epistemonicus. We identified 1,218 overviews published between 2000 and 2020, and 3/4 of us were published in the most recent 5-year period. We identified 332 overviews that were published in the year 2020, which is equivalent to 1 overview published per day. The majority had 4 to 6 authors on the author team and took on average 1.6 years to produce from search date to publication. So of these 1218, we analyzed 541 overviews in more depth, and these were from 2000 to 2018. These were published in 307 journals across these 3 databases, and the most prevalent of these journals being the Cochrane database of systematic reviews, PLOS One, and Sao Paulo Medical Journal, as seen here on the left in our table. We found a median citation count of 8.5 citations per overview per year, published in journals with a mean journal impact factor of 4.4. 70% of overviews were published in journals with impact factors ranging between 0.05 and 3.97. That's 70%. And then in multivariate analysis, overviews with high number of citations and journal impact factors had more authors, had larger sample sizes, were open access, and reported funding sources. So in conclusion, our 20-year bibliometric study is the first of its kind to identify and characterize overviews across 307 journals indexed in 3 databases. We found an 8-fold increase in the number of overviews published between 2009 and 2020, which illustrates their increasing popularity and demand. We found in general there was 1 overview published per day. We also found that the average citation rate for overviews was above average for the journals in which they publish, and therefore may contribute to increasing the 2-year journal impact factors of those journals. And citation analysis and impact factor metrics can quantify, compare, and communicate the influence of overviews of reviews for decision makers. So in our next study, we tried to look at overviews, whether overviews were being published on the same topic. So as a background, several author teams have expressed concerns about the volume of systematic reviews being published, which are overlapping in content. Overviews are also growing in number, and it's unknown whether overviews or reviews are overlapping in content themselves. Multiple overviews conducted on the same topic, which we call overlapping overviews, represent a waste of research resources. They can also confuse clinicians, policymakers, and other decision makers that are making decisions about competing treatments. So then our objectives for this study were to categorize overviews as being narrow or broad in scope, assess if overviews overlapped in PICO eligibility criteria, and then categorize overlap into our taxonomy as identical, nearly identical, partial, or subsumed based on their PICO eligibility criteria. So we defined a broad overview as addressing first more than one distinct population or a generalized population, and second, multiple interventions such as aerobic exercise and resistance training for one outcome of interest. We define narrow overviews as covering only one population and one intervention. So as seen in the tables at the bottom of the slide here, in blue, broad overviews aim to answer broad questions, have a wider range of study populations, condition, interventions, and contexts, are more resource intensive, allow for policy relevance. For example, overviews have informed clinical practice guidelines and government health policies. And in pink, narrow overviews aim to answer narrow, focused clinical questions, identify and explore reasons for variation in systematic review, results, interpretations, or conclusions. They can be completed more quickly compared to broad overviews, sometimes, and may have limited generalizability to different populations and settings. So what is topic overlap? So we define topic overlap as duplication of PICO eligibility criteria and not reported as an update or a replication. We further created a taxonomy of 4 types of overlap, namely identical overlap, where the aims were identical to another overview, nearly identical, where the population, intervention, comparison, and one outcome were identical to one other overview or more, partial overlap, where one component of PICO was common to one or more overviews, and subsumed, where the full scope of population, intervention, comparison, and one outcome was fully covered by a second, broader overview. You could see here on the top right that the gray is totally subsuming the blue overview. So observed overlap can be legitimately justified for several reasons. For example, differences in purpose, out-of-dateness or emergence of new evidence, inappropriate or invalid methods were used, low methodological quality of a previous overview. Existing overviews are narrow, therefore broader overviews are warranted, which combine all the evidence, and or replication by independent and conflict-free academics. So of the 541 overviews we examined, 169 or 1/3 overlapped across similar PICO eligibility criteria and fell within 20 out of 22 WHO ICD-10 medical classifications, as seen here on the left in the bubble chart. Of the 169 overlapping overviews, no overviews were found with identical aims and PICO criteria. 15 or 9% had nearly identical overlap. The majority, or 73%, had partial overlap. And 31 or 18% subsumed others. There was often overlap between the scopes of different systematic reviews without them being coterminous, because some cover broad and other narrow topic areas. So here's an example of 3 overviews that were found on the topic of acupuncture for palliative cancer care. These overviews were partially overlapping in various combinations of their populations, interventions, and outcomes. Overview A by Wu, seen here in blue, had the broadest set of interventions, namely any type of acupuncture therapy for cancer patients receiving palliative care. Overview B by Towler, seen here in red at the top, addressed a narrower intervention, namely acupuncture, excluding any acupressure therapy, for a slightly broader population of cancer patients receiving palliative or supportive care. And Overview C by Ezzo, in striped black and white, had the narrowest intervention, namely acupuncture on point P6, and investigated the broadest population, cancer patients with chemotherapy-induced nausea, and the highest number of outcomes, namely vomiting, postoperative nausea, and vomiting and pregnancy-related nausea and vomiting. So nausea and vomiting were outcomes common to all 3 of these overviews, and partial overlap across the 3 can be seen in purple, as I press here. We note that not one overview fully subsumed another. So our methodological assessment identified 31% of 541 overviews dated between 2000 and 2018 that overlapped in content across 20 WHO ICD-10 medical classifications and 62 subtopics. Though we observe slight differences in the scope of the overlapping overviews, we feel that at least some of the multiplicity represents unnecessary overlap. Our taxonomy of overlap can be used by other methodologists studying overlap across other study types, such as systematic reviews, but especially for overviews. Although future research into overlap in these other study types using our taxonomy is needed. Currently, there's no dedicated database registry for protocols of overviews, such as those for systematic reviews like Prospero. So a dedicated database for overview protocols, as well as the development of a mesh term for overviews, would help in their identification. And then overviews of reviews can use the study and the sample of overviews to identify gaps in the evidence for future analysis and topics that are already studied which do not need to be duplicated. A multiplicity of overviews on the same topic adds to the ongoing waste of research resources, time, and effort across medical disciplines. So I'll now present our research on how to handle overlap in primary study data across systematic reviews on the same topic. So what is overlap in primary study data across similar systematic reviews? Overviews with multiple systematic reviews on the same topic often contain overlapping data from the same included primary studies. As an example, in Figure 1 shown here on the left, we have 3 reviews, each containing randomized control trials, shown by the green tick marks. Review 1 contains 3 trials, Mitchell, Henry, and Nguyen. Review 2 has 4 trials, and Review 3 has 3 trials. The trial by Henry overlaps across the 3 reviews, and the trial by Nguyen overlaps across Review 1 and 2, shown here in yellow. So why is overlap a problem? Overlap is a problem of precision, not bias. Overlap in effect estimates give meta-analyses undue statistical weight due to the duplicated studies and produces overly precise effect estimates. For example, duplicated sample sizes and treatment events produces risk ratios with narrow confidence intervals and more precise estimates. So what methods are used to deal with overlap? First of all, you could select one systematic review based on eligibility criteria, like, for example, the highest quality systematic review. You can visually present overlap, such as the figure that we see here on the left, and quantify overlap, for example, using the CCA or correct covered area, which was developed by Dr. Dawood Pieper. Or you could select one systematic review at the data analysis stage. For example, the one systematic review that was the most recent with the most trials. These are just examples. So in order to get through this presentation, for this study only, I'll skip to lessons learned. You can go look at the study yourself on your own time. So there were several approaches to manage overlap, which we illustrated in 6 case studies. What we found is there was not one standard methodological approach to manage overlap. It was very specific to the number of systematic reviews and the context of the overview. However, we did note that overlap should be dealt with at the outcome level. And we also noted that choosing one review eliminated overlap, but it may not represent the totality of evidence on the topic, and it resulted in a loss of data. However, examining potential reasons for different results or conclusions across reviews was highly resource intensive. However, it can be informative and may also resolve the overlap. So now we'll move on to our study of the replication of the Haddad algorithm to assess discordance. So the increase in the number of systematic reviews over time means that overlapping and redundant reviews are increasingly found on the same clinical, public health, or policy questions. Conflicting results or conclusions of cross reviews and perhaps overviews on the same topic can confuse or create uncertainty for decision makers who are required to choose among all competing interventions and may impact and delay clinical or policy decision making. So an algorithm was published in 1997, which we can see here in this figure, by Haddad and colleagues to aid healthcare providers and policymakers select the best evidence, systematic review or reviews across multiple with pairwise meta-analysis of randomized control trials. So our objectives were then to identify discordant reviews that use the Haddad algorithm to assess discordance across conflicting systematic reviews with meta-analysis of randomized control trials, and try to replicate Haddad assessments done by authors to determine if the same systematic review would be chosen. So we have some definitions in advance here. So we define discordance as when systematic reviews with identical or nearly identical clinical, public health, or policy eligibility criteria, as expressed in PICO, report different results for the same outcome. And a discordant review aims specifically to assess discordance in results across multiple similar systematic reviews. So we searched Medline, Epistemonicus, and the Cochrane database of systematic reviews. We included any study using the Haddad algorithm that had a minimum of 2 systematic reviews with a meta-analysis of randomized control trials. We used consensus building strategies to operationalize the algorithm and to ensure a consistent approach to interpretation. We included studies We actually used 2 authors to independently extract the primary intervention and outcome, and we used a blinding process to delete content related to Haddad results so that our researchers were not biased. So for our results, we've identified 21 studies that use the Haddad algorithm to choose one or more systematic reviews on the same topic. In 62% of the cases, these were not replicable, and ultimately we chose a different systematic review than the overview authors. Overall, 18 out of the 21, or 86%, agreed in the direction of effect, despite 62% of these having chosen a different systematic review than we did. Some Haddad algorithm steps were very vaguely described by Haddad, making it difficult to operationalize, interpret, and use the algorithm. So, in conclusion, our results suggest that the Haddad algorithm is not reproducible between users, and there was no prescriptive instructions about how to operationalize the algorithm. So, in absence of an algorithm to assess discordance, we recommend that authors use relevance, that is, objectives or eligibility criteria that most closely resemble their question of interest, as well as recency, which is the dates of the search strategy, as well as comprehensiveness, that means the most trials are included, and where it is high quality or low risk of bias in its conduct. Our study highlights the extent of time, complexity, and expertise needed by experienced researchers to manually assess and compare systematic reviews that differ across their results and conclusions. So I'll now move on to our survey of decision makers to determine how they compare and choose amongst competing systematic reviews on the same topic. So as a background, systematic reviews are of importance to frontline clinicians, guideline developers, policymakers, and commissioners of health research who need to make decisions about the most effective and safe interventions and policies for patient care. As noted before, confusion arises when more than one systematic review is found on a given topic. So it'd be valuable to know what variables or features that policymakers, practitioners, and other types of decision makers choose when comparing multiple systematic reviews. We therefore aim to survey decision makers to understand how they use and select one or more systematic reviews, if they encounter them, and learn what features they consider most important when choosing across reviews on the same topic. So our methods were, we actually developed an electronic cross-sectional survey with 20 open and closed-ended questions. One question about the features they would consider important when comparing systematic reviews was randomized. We followed a knowledge translation plan to disseminate the survey through social media and professional networks. And our results were that we had 684 respondents. A quarter were clinical practitioners, 9% were policymakers, and 39% were researchers. Most of these sometimes or often sought out systematic reviews as a source of evidence in their decision making. And the majority often faced a situation where they found more than one systematic review on a given topic of interest to them. About 40% struggled to choose the most valid and trustworthy systematic review. And these difficulties in choice related to a lack of time, skills, and/or experience for quality appraisal, and difficulty comparing different systematic reviews on the same topic. These decision makers considered the following features very important when comparing systematic review. First of all, the relevance of their question of interest to the systematic reviews question, recency of the search date, and methodological quality or risk of bias of the systematic review. So, one of the recurring themes that came up when analyzing the free text comments in our survey was that many said that there's not one best review in the real world that they would choose. While a review may have a good MSTAR quality, so it would be high quality, it still may contain important flaws or may not report important outcomes or other data that may be important to decision makers. So to get the most out of their decision making, the respondents commented that they would often review and read all systematic reviews on their topic to assess their strengths and weaknesses. So our survey informs the development of a new tool to facilitate the selection of systematic reviews, which would be automated, and it's called Wisest, and we would also be incorporating the features important to decision makers into its development. I'll now move on to the last protocol, which is a development of the Wisest AI tool to automatically quality assess and compare the PICO methods and results across systematic reviews on the same topic. So as a background to our protocol, evidence-informed practice policy and guideline development requires quality appraisal to choose the best evidence. However, the manual process of assessing the quality of systematic reviews using tools like MSTAR 2 or Robust, it's time-consuming, it requires skills and training, and can be costly. So an automated method for comparing systematic reviews on the same topic and selecting the best evidence currently does not exist. So we therefore aim to develop an AI approach to model quality appraisals for systematic reviews and to compare PICO criteria and other methods called features across the reviews. Our specific objectives are to select features that will be used to compare overlapping systematic reviews, create a labeled dataset of 10,000 reviews that are clustered by topic, and train, test, and validate machine learning models and compare their accuracy. So 3 studies, 2 of which we have highlighted in this presentation and a third that's being analyzed, inform our first objective to select features to include in our models. Our in-progress qualitative review aimed to identify features used by researchers to identify discordance across reviews with the same PICO questions, which is this study 3. We will use these 3 studies to identify features to include in our models, as well as quality indicators that will be based on AmStar2 and Robust items. So many tools exist to assess the quality of systematic reviews. We conducted a systematic review of all tools used to assess the quality or risk of bias of systematic reviews and found over 57 tools. Only 4 of these tools underwent rigorous development, including testing of reliability and validity. However, due to the very different nature of each of them, there has been no conclusive evidence about which to choose. But I'll show you two tools in general, AmStar and Robust. So this is the first AmStar tool which was developed. And it's very popular. So AmStar asks 11 questions. Responses for each judgments are yes, no, can't answer, or not applicable. Some report a summary score, usually assigning equal weight to items, which may be difficult to justify and is not recommended by Cochrane or other methodologists. And in this AmStar 1, some authors stratify reviews as high, medium, low quality using the cutoffs from the scores. Again, this is not recommended. So a new AmStar 2 tool, which is seen here, aimed to eliminate this kind of arbitrary cutoffs or scoring. And it includes items related to quality as well as bias and reporting. So here is the third tool, which is the Robust tool, which is a newer and comprehensive tool designed for appraising the risk of bias in reviews. As opposed to AmStar, it uses risk of bias domains to assess the quality to assess the risk of bias of the review, much in the same way that the Cochrane risk of bias tool for randomized control trials does. So our second objective is to create a labeled data set of 10,000 systematic reviews which are clustered by topic. Labeled data consists of a set of examples of correct data that the machine can learn from. We show the machine the correct answers and the machine tries to predict or learn from it. To create our data set, we approached 4 organizations with databases of pre-appraised systematic reviews. They were then recruited as collaborators on the project and as well as a grant application, and they will be supplying us with 8,450 AmStar assessed systematic reviews. So actually, as a plug, if you or your organization have conducted any AmStar or Robust assessments on systematic reviews, we would love to hear from you and collaborate in order to get these assessments to use in our machine learning data set. So the features we extracted from our data set will be relevant text like, for example, publication bias. And the features will be used to train the models through a process called machine learning. Our model is created via this training step. Our data will be split in 3 parts. The first part used in training our model will be the majority of the data set. The second part will be used for evaluating our model's performance, and a third set will be used to validate or test our finalized model one last time. So we don't want to use the same data that the model was trained on for evaluation, since it could then so the AI could just memorize the questions. Just in the same way as we wouldn't use the same questions on our math homework on the math exam. So our steering committee made a few conceptual decisions about what the tool would look like. First, we decided that systematic reviews will be included if they focused on healthcare interventions, were conducted with or without meta-analysis, and could include randomized or non-randomized studies. Users will upload the reviews as PDFs onto the website or app, as seen here on the left. And then the text extraction from the system will extract quality indicators as well as features, and such as the PICO. And the output will look like something on the right, where you see the participant intervention and outcomes for this TUI 2018 review, the number of primary studies, and some of the quality questions here above. Were PICO eligibility unambiguous, or was there appropriate range of databases searched? The user will be able to choose for themselves which systematic review is best suited to their needs. They'll also be able to provide corrections to the data that the AI presents through a user feedback loop. So in conclusion, our wisest tool will have a potentially large impact due to time saved compared to manual approaches, as well as a broadened audience of decision makers who normally wouldn't use a manual tool to assess a review. The wisest tool with functionality to extract PICO, methods, and other features allows a flexible approach tailored to the needs of the user. And with our wisest AI tool, decision makers will be able to evaluate the validity and applicability of reviews automatically, thus potentially increasing the uptake of applicable high-quality evidence and ultimately improving patient outcomes. High-quality overviews of reviews give the best perspective on our current state of evidence on a subject for decision makers. Gaps in methods for overviews that we addressed in our recent research include overlap taxonomy based on PICO eligibility criteria, management of primary study overlap across systematic reviews, an assessment of the DAD algorithm to assess discordance, and criteria that decision makers use to compare similar systematic reviews. Many other gaps exist related to the issues that are unique to overviews, and we encourage groups to take on research to advance this methodological field. So I thank you for your attention, and I welcome any questions.
On Zoom, and we will call on you.
Great, thank you.
We have a question from Sarah Neal Stramka. She asked, were you able to look at potential reasons for overlap, like different dates or quality of reviews?
Yeah, so for that study, we were only looking at the overlap across PICO eligibility criteria. So it was really just for that reason, because really when you're looking at like either systematic reviews or overviews of reviews, you want to be able to assess whether your question of interest, say you have a patient, with, menstrual pain, for example, is that question that clinical question that you have, is that going to relate to the systematic review or the overview of review? And so the way you would assess relevance or applicability is you could use, for example, our taxonomy if you wanted, to go more in depth with it, to make sure the question of interest really matches your group of systematic reviews that you have.
Can I just ask a quick follow-up? Thanks so much. So that my question was about the first study and looking at sort of the prevalence of overlap. And I'm asking because I lead a team that conducts we started conducting rapid reviews for public health decision makers during COVID, and now have sort of pivoted a little bit to taking on other public health questions as part of the National Collaborating Center for Methods and Tools. And so one of the things that we came across through the pandemic in particular, where so much was happening so fast, and so that was a lot of the reason for overlap, was just the speed at which things were coming out. But we still see it now as we move out of that, is when we have a question from a decision maker. And so we go to do a rapid review and we look to the evidence and we see other reviews on the topic. However, the quality is quite low oftentimes, so we've kind of created some sort of internal criteria for us to think about, are we going to do a full rapid review of single studies? Are we just going to rely on reporting the systematic reviews that have been conducted? So, some of the things we look at is, have they included critical appraisal? If they don't, then we're not using that review to present to decision makers. We're going to go look at the single studies ourselves. So we've sort of kind of come up with our own internal criteria, and a lot of that being in a rapid review is also kind of based on feasibility of timeline and number of studies. But I was just sort of curious, when we've looked at questions and we look at reviews first, as we kind of go down our hierarchy of evidence from a rapid review perspective, so often, unfortunately, we see a number of reviews on similar topics, but either they're outdated, which, then we need to look at more current evidence depending on the question, or they're just really of low quality. And so while there may be some reviews that really overlap highly, the quality is so low. So we end up conducting our own because we don't feel comfortable presenting that to decision makers. So I was just sort of curious, when we look at the prevalence of overlap, certainly I agree that there's lots of research waste out there, but I'm curious as to how much it's still waste, I guess, if a review has been previously conducted, but of poor quality, but just how much of that overlap is reasonable versus unreasonable. Anyway, just sort of curious about it. And then if you know of any kind of criteria for, when you are conducting, when you have a question from a decision maker or a policy maker or a clinician, what are any guidance on how do you determine whether you need an overview of reviews, whether a full systematic review is appropriate? Just curious if you have any thoughts on that.
Yeah, so it's a hard question, because with overviews, it's a bit different than systematic reviews. I think it's like you could say, okay, yeah, there is research waste for sure in systematic reviews on the same topic, but with overviews, it's a bit trickier, because the reason why I presented that kind of data on broad versus narrow, and the subsumed, is to give people a better idea of okay, so you can have one really broad overview, for example, that encompasses all the evidence, and then you can have one really narrow one, and both are equally valuable, to researchers. Maybe I want to just go to the bottom line, for this one topic, and that narrow overview answers my question. Well, I'm going to go straight there. So it's a little bit I don't want to say there's research waste in overviews necessarily. We did find some overlap, but I don't want to go that far. But I do think that, with systematic reviews, there probably is definitely waste going on, as I think everybody here is well aware. And then, so Sarah, did you ask so with rapid reviews, kind of what process would you go through to be able to see if there was discordance, or is it about the overlap more?
No, so I guess my question is, if you know of any guidance or have any thought, published guidance, or if you have any thoughts around what would some of those criteria be for someone to go, if you have a question from a decision maker, or you have a research question as a researcher, and you first go to the literature to see, has anyone already done this? you see that there is some work out there, you know, what are some of the criteria that you would use to make that decision on whether, you know, is it an overview of reviews that's needed to answer the question? Is it sufficient to rely on the single review that you have, or a few systematic reviews that you have? Is it warranted to do a new systematic review? I mean, we've kind of looked around and haven't found anything, but just curious if you know of anything else that might be out there to help guide those decisions.
Yeah, actually, so we haven't done work on that, but I mean, it really should be guided by your research question, right? But actually, I do know that the Joanna Briggs Institute is actually doing really great work to answer your question, actually. So they're coming out with I think imminently with research, and you could actually reach out to the people at JBI. I think James, do you know some of their names? I can't remember off the top of my head. I don't want to get it wrong, but Sarah, if you here, I'll put my email in the chat, and I can get you in touch with them actually, and they could provide you with their research actually, which is great.
Yeah, that would be great.
In general, yeah, I think if you wanted to answer a really broad question, I would use an overview where you're like combining a lot of different interventions together. I mean, if there was a network meta-analysis and it was a more like focused topic, like very narrow topic, I would use a systematic review to answer that. But in a lot of cases and in a lot of fields, for example, humanities, there's no network meta-analysis out there. In which case, if you had a narrow topic, I would definitely do a systematic review, and then maybe just update it, with the most current evidence that you have. I mean, these days, sometimes, especially if the data sets are available, they're not in a lot of cases, but hopefully that's going to be changing in the near future.
Great, thank you.
It actually connects to one of the other questions from the chat. Katya asks whether overlap might become less prevalent once pre-registration of protocols becomes some more standard practice in this area. Do you have thoughts about that?
Well, I don't know, James, what do you think too? I think, we haven't really seen that much progress with protocols kind of improving either the quality or, anything else around, systematic reviews. We don't have any research on protocols for overviews and how, they might change in the publication stage, but I doubt, just as I doubt that they would actually help with overlap. I doubt. I mean, maybe some centers go look into Prospero, for example, for systematic reviews, but currently their overviews of reviews are not accepted in Prospero. Although I was told by Ian Saldana, who runs who kind of is getting on board with kind of updating Prospero, that they might be including overviews of reviews now in the future because they've gotten more funding for that.
Thank you. And we have another question from Sabina Slimy. She asks, how are you addressing reproducibility with your overlap guidance?
Sorry, how do we look at reproducibility?
Yes.
How do we address reproducibility with the overlap? Well, that's a good question. I think reproducibility in overviews of reviews is very difficult because there's so many. First of all, I think part of my presentation cut off when I was muted is I was actually describing a new reporting tool for overviews of reviews called the Prior tool. And that's sort of similar to Prisma for systematic reviews, but it's for overviews. And the whole wish is that these reporting tools. So how do you describe your research in great detail? So when you publish it, so that people are able to reproduce your systematic review or your overview. But in reality, a lot of these decisions that you're making for overviews are are complex and you need a lot of decision rules, and a lot of that isn't really reported by authors just because it's too much information, right? So I think reproducibility will be quite difficult for overviews.
Thank you. Another question we have is, what other important gaps can other groups take on in meta research about overviews?
Yeah, so that's a great question. One of the things that we don't currently know a lot about is about, what is the quality of overviews, for example. So, we have the Amstar tool and we have the Robust tool to assess the quality or the risk of bias of overviews, of systematic reviews, but we currently don't have a tool for overviews or reviews. And so there's a lot of overlap with the methods in systematic reviews, but obviously there's a lot of like very unique scenarios in overviews, some of which I highlighted today, but there's more than that as well. And so I think eventually developing a tool to assess those unique aspects of overviews would be very valuable. I do know of a group too that's doing grade for overviews, although I think that research is being done by the grade guideline team. That's been in development for a while. And I think that's because, the complexity of looking at the evidence at the overview level is quite difficult. But I mean, those are just two examples.
And then we have a question from Ayat Ahmadi. They said, yes, not considering the overlap in overviews is likely to overrepresent all trials in the overview conclusion. If the estimated effect was time dependent, it might cause tendency toward those older trials. And would that be a kind of bias?
No, so when you have a lot of overlap between the trials, so you have overlap in the sample sizes across the trials. You also have overlap in the events that are happening. So, say for example, we have a whole list of trials, and we're combining them because we have a whole bunch of overviews. And so say trial, 1 overlaps across like 3 trials. So that means that we have 3 times that sample size, which is being used in that one trial that overlaps, right? So that's not a question of bias, but it's a question of precision because the sample size is tripled. Number of events is tripled. So that means that in the meta-analysis, that trial is going to be very precise. So it's going to have, in a meta-analysis, you kind of weight the studies based on sample size. So if that sample size is tripled from the same study being, represented 3 times, then it's going to have more weight in the meta-analysis, which is wrong. And it's going to be overly precise. So it's not a question of bias, it's a question of precision. And if you look at the different domains in grade, precision is one of them. So I would encourage you to look at the grade guidance and look at those different categories. One of the categories is bias, another one happens to be precision.
Maybe I'll exercise the chair's prerogative here. I was wondering about what your plans are for disseminating this sort of machine learning tool for assessing the overviews, and in particular, it strikes me as like Campbell's law might become relevant, right? The idea that like once you've got an assessment that is being used for decision making, if that is that is a process in society, then the inputs to the assessment become corrupted, right? Like somebody that's doing one of these things and now knows how it's going to be assessed, right, might include superficial markers that will give it a good grade, but without actually doing the underlying work.
Okay, so I guess I don't really understand. So you're saying that the AI could be corrupted, right? To be able to find whatever estimate you want to. Is that what you're suggesting?
No, I'm suggesting, I mean, the algorithm might be good, it might be fine, right? But once that algorithm is in place and being used to make policy decisions,
Yeah.
then there's now a new incentive for the producers of the evidence to try to optimize to get a good score on the algorithm. And there may be ways to do that other than conducting a high quality study.
Yes, and is that also the case that you could do that manually? So people could, manipulate the data if they want to get a result that they want.
Sure, but I guess like it might be very easy to fool the algorithm, right? Like, so if one of the assessments that it's predicting is like was there a risk of bias assessment, right? So then maybe embedding any sort of text in the document that talks about risk of bias might be enough to get it sort of a good score on that
You're
dimension,
right, actually.
right?
Yeah, and very, very true, and a great point, actually. That is very true. It could be manipulated. But I believe that like every research, all research could be manipulated. So I mean, I don't know how we could like mitigate that. Do you have any suggestions?
Well, I mean, I guess like you know people talk about Campbell's law in all sorts of different contexts, right? Like, in education, we think about like, well, you know, once school quality is being assessed in terms of performance of the students on standardized tests, right? There's now incentives for the schools to, do unscrupulous things to get high test scores without actually doing a good job of teaching students.
Yeah.
And I think the main sort of takeaway from that sort of, the implication of Campbell's law is that there's sometimes just there's no easy way to generate quantitative assessments. Sometimes you just have to come up with like robust, possibly qualitative, labor-intensive systems, right?
Yeah,
So
I agree.
I don't know if that's useful or not.
Definitely. Yeah, I mean, like we're trying, like I said, we're testing it on healthcare research, but we actually have a data set of social and humanities systematic reviews as well. So we do want
Oh.
to expand it to those two. We might just go right ahead and do it with everything. I'm just not sure right now. So I wanted to be cautious and say it's just going to be healthcare, but we
Okay.
do want to have it expanded, which is some data sets from McMaster actually.
It's really interesting because like I'm thinking about like the use of automated algorithms for study identification and data extraction in like systematic reviews on a given topic. The work that's been done there is largely in clinical research, health research, where
Yeah.
the structure of the documents is much more defined than it is in social science. I don't know if
Okay.
you have a sense of like, if you were going to apply this to, overviews in health as well as overviews in psychology, say, or
Yeah.
humanities. Are there like sort of qualitative differences in the structure of those documents?
Yeah, like I mean, you probably know, but I always say that I actually hope that people start plagiarizing because like we want, plagiarizing methods sections because if they started like, using the same sentences, over and over again to denote, say for example, we did a risk of bias assessment, if people said that in every single publication out there, it would be very easy for the machine to pick that up, in the humanities or like in medicine. But yeah, I don't really have a sense. I think you're right. I think there might be like different structures to the social sciences reviews. So, I mean, we're just going to have to look at that. But I do have a sense that we're not going to be asking the machine to look for certain information in like a certain section. We'll have the information about where it was found. But I think, if that information is found in a different section of the document of the document, I don't see that as a problem. But you're right, it could be
Yeah.
about language, right? Maybe it's like said differently.
Yeah. Sarah, did you have a comment? You had a comment in the chat. Are you still on? Maybe we lost her.
And she was just, I think, giving some examples of when they had looked at, yeah, I think she was just giving examples of people, of researchers saying they had used the risk of bias tools, but not really showing results, or yeah.
Yeah.
And Katya also, I think, linked an article of that.
And what did you look at, Kamal? Did you look at the article? What is it?
Oh, I did not look at the article.
It's using machine learning to for the evidence retrieval stage in a system.
Oh, okay, got it. Right. Yeah. So ours is not for like finding the evidence, but it's for assessing systematic reviews.
Right. Articles like that sort of illustrate the how tricky it is to do methods research these days, because it's a methodological review, but they had to do it systematically. You can't do an asystematic, methods review if you're in the field of synthesis.
That's right.
Yeah. Well, we're at time. Actually, we're over time. So I think we'll call it there. Thank you very much, Carole, for sharing your work with us. I really appreciate it.
Yeah, and thank you for the opportunity for presenting. I really appreciate it.
And anyone who's still on, we will have another, the next entry in our seminar series will be a month from now, November. Diego Campos will be presenting on methods for individual participant data meta-analysis from complex sample surveys. So things like PISA that have a complicated sampling design. So join us then. Take care.
Thanks, everybody.
Thanks, Carole.
Thank you.